listening to CMDA Matters, the weekly podcast of Christian Medical and Dental Associations. Here's your host, Dr. Mike Chupp.
Welcome, friends, once again to the podcast where we always focus on educating, encouraging, and equipping Christian healthcare professionals to glorify our God. This week, I did something fairly unusual. I literally called an audible and changed the program completely. In light of the global ripple effect of the recent closure of the United States Agency for International Development, or USAID as we all know it, and many messages and social media posts that I have been reading from friends of CMDA, as well as kingdom workers around the globe, I reached out to a couple of healthcare professionals who have personal experiences and insight into this funding crisis. Dr. Jeff Barrows and I had the privilege this week to speak to two very influential women who are highly invested in global healthcare, particularly in sub-Saharan Africa. This two-part interview today will examine in real time the effects being felt across the healthcare missions community with the government's reevaluation and realignment of United States foreign aid through USAID. Our first guest, together with her husband, were actually the 2022 CMDA Missionaries of the Year from the country of Eswatini, which is in the southern part of the continent of Africa, Echo and Harry VanderWal. Jeff and I caught up with Echo on her way back to the U.S. from a gathering of global healthcare workers and leaders in Southeast Asia. I think that you will find her experience with USAID and funding in Eswatini, as well as her perspectives on this crisis of funding, well, a bit surprising. So just listen in. Well, friends, it's not all that often that we have a topic or a guest in which there's a situation that is rapidly evolving. But this week is an exception to that because we have reached out and recruited a couple of guests for the program this week to talk about essentially the closure of USAID and the stoppage of funding around the world for global relief and global health. And this is obviously, Dr. Barrows, who's with me in the studio today, a topic of advocacy. So thanks for joining me today.
Sure, Mike. It's great to be here, even though this is a fast-moving train.
It is. So even over the weekend, any updates to share with me that you read about?
Well, we do know that, first of all, there was a waiver granted about a week ago for all, I think, the majority of PEPFAR funding. But I understand that this last Thursday, a judge did rule that the administration's stoppage of all USAID funding is not in line with his thoughts. He wants to put a pause on it and look at it in a closer manner. So we're not sure what that means in practicality and on the ground, and we're hoping that Echo can address some of those concerns.
Well, in my lead up to our conversation today with our guest, Echo VanderWal, I shared just a little bit about my own experience in receiving USAID funding or American Schools and Hospitals Abroad, a branch of USAID, over the years in Kenya. And it won't surprise any of our listeners, and especially the 800 or 1,000 of our members who are global workers around the world, that there's been a great deal of crisis communication happening. And it just so happens that many of those global workers were together in a far-off place in Asia. And our guest today was one of those. So welcome to the program, Echo VanderWal.
Thank you very much. Thanks for having me.
So you were together with a couple of hundred folks who serve globally, and I suppose there was a minute or two that you spent talking about this closing down of funding from USAID.
Yes, Asia was my second stop. My first stop was in Rome, where I was invited to the Vatican for a leadership dialogue around pediatric HIV. So that was even closer to the announcements. And, there was most of the global leaders from around the world in the room that have been involved with HIV and TB over the years. So definitely a crisis and a challenge that I think is something that everyone's trying to wrap their hearts and minds around.
Well, I should let you listeners know that Echo and her husband Harry, who serve in Eswatini, are very special people. So special that our board of trustees about 3 years ago said that they should be recognized as our missionaries of the year. And so in Indianapolis at our national convention, they received a plaque, and we saw a video, the story of how Echo and her husband Harry have made a massive difference in the country of Eswatini. So before we jump into talking about PEPFAR funding, would you tell us just a little bit about your work as the executive director of the Luke Commission in Eswatini?
When I was 8 and Harry was 17, we felt called to work overseas in healthcare, and we didn't know where that would be or what it would look like. But when Harry was finishing his residency, we had the opportunity to visit Eswatini, formerly Swaziland, for the first time in 2004. And what we didn't know is that we were going to drop into the epicenter of the HIV crisis on our first trip. And what we saw there on the ground was very devastating. A country with the highest HIV prevalence rate in the world. Everywhere we went, every house we went to, young people were dying from HIV. And when Harry finished his residency, we left to go there with our 4 young sons. We had triplets that were 3 and a 2-month-old when we went, and it has been our home for the last 20 years. So I definitely have journeyed in a very deep HIV crisis through moving to epidemic control, meeting 95 is the first country in the world to do so, and have experienced the pain and suffering that comes with HIV. And over the years have moved from a team of 10 people, initially with Harry and I being the only healthcare workers on the team, to a team of 700, providing 300,000 outpatient visits a year and admitting 88% of the ICU cases in the country, doing the majority of the snakebite work. Our team has just done an amazing job of learning the heart of compassion and the power of innovation and technology to be able to serve large numbers of people with high accountability and transparency and integrity. So we're able to stretch a dollar a long way.
And I understand that you and your husband started and do this under the name of the Luke Commission, so I want to make that clear to our listeners. So, Echo, how many of the Luke Commission health programs there in Eswatini benefit from either PEPFAR, or it's obviously part of USAID funding? And to what extent are these programs dependent on that U.S. funding?
Thank you. It's a good question. And it's one area of advocacy that we've worked in a lot in the last 5 years. Maybe just to step back a little bit, during COVID, our facility ended up admitting 90% of the COVID ICU cases for the whole country. We also built an oxygen plant because we were dependent on South Africa for oxygen. And we also built a digital ecosystem to capture all the vaccinations in the country for COVID. So we did quite a lot of work during COVID. And that challenge that you've just raised became more and more visible in that we were really way too dependent on foreign aid for things that we should be carrying or should be sustained by our local government. And so we have been advocating at national level with our local government to make sure that we're putting our national healthcare budget to good hard work in Eswatini to make sure that we are providing high quality care for the lowest possible cost. And while we've been very, very grateful for the investment of the United States government and other international funders over the years, definitely moving towards local sustainability has been something that we've advocated for. Because I can tell you during COVID, there was a lot of funding coming in, but it wasn't really being allocated to where the work was being done. And you started seeing the challenges in coordination, definitely during COVID, where there were funds that were being directed to places that weren't really doing the lion's share of the work. And obviously now we're sitting with the lion's share of the work and the funding's going other places. And so equitable allocation of healthcare resources is something we've been advocating for at national level for a very long time. Because during COVID, basically the majority of our hospitals closed and we were the only hospital that was taking COVID cases. And it was very difficult because we didn't have oxygen and we had to ask ourselves very difficult questions because we had committed 20 years ago to taking care of every person as our own father, mother, brother, sister, child. So what do you do when your mom is suffocating because there's no oxygen and you don't have the one thing that she needs, which is oxygen? You continue to hold her hand because that's what compassion and our faith expects of us and demands of us. But definitely we saw the disparities in allocation of resources going to places that were really not doing the work. So our pain that just started a month ago for a lot of people in global aid has actually been ongoing for 5 years.
So clearly the sub-Saharan African country with the highest incidence of HIV/AIDS and PEPFAR funding has been around for quite a number of years. And so have you for a number of years, as you've just explained there in Eswatini. So a big difference in HIV/AIDS care because of PEPFAR funding, and you've obviously made a difference in the midst of COVID and turned that around. And I think that those were the stories that I heard in Indianapolis, the setting up of an ICU and ventilators and oxygen and saving people's lives. So could you give some examples then of how what happened a month ago has impacted your care, and in particular, I believe HIV/AIDS because of PEPFAR? All kinds of communications go back and forth. And, what I've learned over time, Echo, is that not necessarily everything that you hear secondhand is true. So I heard that you were closing the doors of the hospital because of this. So tell us, it's great to hear it straight from your mouth. What's going on the ground?
I tried to set a bit of the backstory because our financial challenges have started during COVID. Prior to COVID, we had appropriate funding for the amount of work we did. And then during COVID, in the last 5 years, the number of people coming to our facility has increased by 300%, largely driven by the fact that we have massive drug shortages in the country. And because of the digital system and digital technology we're using, and I would say a very transformed and focused team that recognizes that supply chain excellence saves lives. So if we have drugs, it's going to save somebody else's mom and my mom. Taking it to that heart level where taking care of other people like we would want our own family members taken care of has really transformed our very big team of 700. So driven by that compassion and dedication to accountability and transparency and integrity, we became the go-to facility for the country. And so, because a lot of this was happening during the crisis of COVID, we started using some of our credit lines that were in place only for emergency reasons to be able to respond to the need, because these people are at our gate dying, and we would let them in. And of course, some of, this was being realized post fact. Then also we took out a loan to pay for the oxygen plant, fully thinking that global aid would come in and assist us with that. It was one of the biggest global stories in oxygen solutions during the COVID pandemic. But unfortunately, that funding got diverted to other places. And so because we had adequate medications, people started coming in huge numbers because that was not available at most of our country's facilities. So when the orders came down from Washington, D.C., we were already in a very financially compromised state because of the role that we had played in the last 5 years, the challenges at national level, the challenges at global level. I have to say that we've worked with USAID for 15 years, and they have been a tremendous partner. They have supported our faith. They have supported our commitment to compassion. They have supported and funded our commitment to advancement of technology to be used to provide a very high quality healthcare service at the lowest possible cost. And at the same time, they've capacitated us from a small organization to a very large organization, having us learn all the U.S. government rules and regulations and all the things that are very critical to being able to take United States government funding. They have journeyed with us. They have been, what I can say in 2 words, a faithful friend. I have to make sure that I make that clear, because the work that USAID has done with us in Eswatini has been nothing but full of accountability and integrity in what we've seen in our context. And during COVID, they were unbelievable. They were working so hard to try to get funding for the oxygen plant, to get funding for ventilators, to get funding for us to be able to take care of the nation. So they really have been a faithful friend.
Before we continue with this week's episode, here's a special announcement for you. For those of us who are called to healthcare through our relationship with Jesus Christ, our question should not be if we are living on mission, but rather where and how we are doing it. Wherever you are in your healthcare journey, we have ways to equip you to live on mission each and every day. If you have any questions about how to get started, learn more through CMDA's Center for Advancing Healthcare Missions at cmda.org/CAM. That's CAHM. Let's jump right back into this week's episode.
Unfortunately, during COVID, there were other U.S. government funding agencies being funded by the United States government in Eswatini that were actually fighting the investments USAID was making. And so there's just been an infighting and almost like a political type of environment around global aid. It's not well coordinated. And I'm hoping moving forward, as much as I will advocate that we need to keep people on antiretrovirals and on TB medications, there are certain health programs that we cannot stop abruptly, that on the other side of will be much more balanced in our allocation of resources. So I set that stage to say that everything that has happened to us as an institution in the last month did not start last month. It started 5 years ago when we did the work and other entities got the funding. And this, I hope, will become more balanced as we move forward in being smarter in the way that we allocate global aid. But when we've also made some progress locally to be put into the national budget, and there's still a lot of work that's being done in that area for the local government to be responsible for their social mandate to their own people, which is to provide one of the most basic human rights, which is healthcare. And so we're still advocating on the ground in Eswatini for that. And it's a bit intense, especially with the latest orders coming down. But what happened then, this came at a time where government had not released the budget, when we are already financially really under tremendous strain because of the last 5 years and our response to COVID and then the other challenges that I've explained. So now when this came, it came at a time where we really did not have a lot of options on the table. So we did, for the first time in our institution's history, put gates on the campus. In fact, we never had gates before. We put them there because we have to control the influx of patients coming in. And what we did is we went to, we have obviously had grassroots level donors. I call them super glue, the Christians that have been supporting us for years, private foundations that have been supporting us for a long time. And we were able to take that unrestricted funding, suspend some of the other programs that were being done with that unrestricted funding, or targeted funding towards other programs like specialized surgical care and some of our snakebite work and stuff. And we reallocated that to making sure that people continue to get HIV and TB refills. So the one thing that we've retained during this temporary closure is that every person who needs to get antiretrovirals and get TB medication, they are getting that. We're also doing surgical follow-up. So basically, Mike and Jeff, what we did is we said, ethically and morally, what can we not stop? With this small amount of money, because now we're not getting funding from USAID, how do we make sure that we take what God has given us and allocate it to the places where we really believe are most need an ethical response? And that for us meant that we continue keeping people on HIV treatment, TB treatment, and continue to follow up any of our post-surgical patients to make sure that their outcomes are maximized. So that's where we're at right now. If you would have asked me 2 years ago, if I thought due to the misallocation or the awkward allocation of global aid funds in Eswatini would have led to this, paired with the fact that actually these misallocations of some global aid dollars were actually fueling artificial barriers to local solutions, then I probably would have told you that unfortunately this may happen. So when this happened last month, we weren't in the first stage of grief. We are very much in a recovery phase. We have plans for a diversified funding structure moving forward. We don't know what that's going to look like. We don't know what God's going to do with this, but our hope and our faith are alive and well. and we'll continue pushing to take care of anyone that we can take care of despite the challenges that are present on the ground.
Praise God.
Yes. Well, Echo, that context is extremely helpful to me, especially as a non-long-term missionary, and I'm sure for many of our members. So thank you for that. And I've briefly mentioned the waiver, and so I'm curious now as to what you're hearing on the ground as well as your experience with PEPFAR in the past about the restoration of funding that the U.S. State Department will hopefully do in the next, if not days, the next few weeks.
So we have heard about the waiver, and of course we've been keeping a pulse on what's going on as much as we can. And so far, the waiver has not materialized on the ground. In reality, in Eswatini, we don't, one of the things that is good about the United States government is they communicate to you in black and white. So we did get, a stop work order telling us to pause implementation of PEPFAR USAID funded activities. So we knew that, and we were asked to write back that we'd be in compliance. So that was there. But we have not gotten in black and white the waiver. We have seen what's been discussed in the press and in other environments, but have not gotten the waiver as of yet. Some of our work should fall under the waiver. So hopefully there will be some, the big thing here is that I really want to stand in the middle of this and say that we needed balance 5 years ago when it came to allocation of global aid funding. We need balance 3 years ago when we really need to move towards more local sustainability. Today we need balance. And our goal for the Luke Commission is to be for a voice of balance. We don't need some of the things maybe that were being provided for, but we do need to continue to put antiretrovirals and TB medications into the hands of people whose lives depend on it. As a person who's worked deep in the bushes, deep in rural areas, for 8 years, it was Harry and I on the ground, only healthcare professionals. I saw things that, you just never thought you would ever see in your life. And that's the devastation of HIV. And we definitely don't want to roll back the clock on that. So, our prayer moving forward is that there will be balance and that we'll be able to move forward in a new era of accountability and integrity and still retain the American value of compassion moving forward, because I do believe it's one of the reasons that God has blessed our nation. Mm-hmm. But obviously, compassion comes with accountability. We are not really compassionate if we're not accountable and we're not transparent and we don't operate with integrity. So TLC is in support of all of those things. We're just hoping that we can come to a balance and make sure that we protect the most vulnerable in the process.
Well, Echo, surely your super glue friends are going to continue to help you over time. But the clock seems to be ticking. There's only so far that your funds that go to other things like snake bites and maybe eye surgery or whatever things that can be put on hold. Is it a month? Is it 3 months? Is it 6 months? I'm assuming those funds are not going to indefinitely sustain you, even in the most critical things like preventing the transmission of HIV from moms to their babies. What's it look like?
We are on a short leash. I can tell you we're on a short leash. While we have had very dedicated super glue friends over the years, to be honest with you, Mike, we have done some things really well and we've done some things very poorly. Growing our super glue base, we have not done well. We've mostly been on the ground, head down, and during COVID, things exploded on us, and we're trying to catch up in the area of bringing more people on board with the work in Eswatini. So definitely need more super glue if we're going to hold it together very long. We probably have between 4 to 6 weeks, and that's going to be people not getting paid full salaries. That's going to be some major pain points that I'm not sure. In reality, our team has been amazing. Immediately when we went on suspension. The other thing I think maybe is not well understood is that some of us are on reimbursable grants and some of us are on advanced deposit grants. So our quarterly voucher went in on the 17th of January and of course wasn't paid out yet, which is normal course. So we had already expended a quarter's worth of funds when this happened. So there's just all those pieces and parts of the cash flow that play a role in it. So that will put us on a shorter leash than if this would have happened maybe at a different time during how the quarter fell. But a lot of our staff are working and only getting paid a portion of their salaries and are volunteering the rest of the time right now. We have a very united, dedicated staff that has been so resilient during the hardest time. So that is carrying us to some degree, but obviously realities of people having to feed their kids will come into play in very short order in an environment like ours. So we're very aware of the fact that people's kids need to be in school and they need to feed their kids, and how long we can make it as we're operating right now, we're not sure. But we definitely believe in a God of miracles. We have seen that from day one in Eswatini. We've worked in several different crises and very difficult circumstances, and we've seen God do things that we could have never strategized or planned ourselves, and we still have hope and faith that he's going to do that even today.
He's paying attention, and you're under his umbrella, his protectorate. Where can our listeners go to find out more about the Luke Commission Hospital there in Eswatini? And I'm sure that you're updating folks out there who you want to pray for you and give and help support you through this time. Where should they go?
You can go to our website at lukecommission.org, lukecommission.org. And then we have, as part of our commitment to doing better in the area of telling the story, have done much better at social media. So you can find us under most any social media handle under Luke Commission or under the Luke Commission. But not 2 years ago, because we weren't good at that. So we've gotten better.
Thanks. Just getting better.
Well, I just want to point out, Echo, that it's extremely clear to me that your work there in Eswatini is so critical and definitely deserving of taxpayer funding. And so it's my hope and my prayer, and I hope the prayer of all of our listeners, that it will be restored very quickly so that you can continue to save lives and do the amazing work that you're doing there.
Amen. So be it. If you would like to learn more about Echo's Hospital, where she is the executive director, the Luke Commission Hospital there in Eswatini, you can check out the links in our show notes today. You will also find Echo's full bio there. So speaking of bios, our next guest served for 3 years in a senior post at USAID and continues to volunteer in different mission hospitals around the globe. She does that almost every other month over the past year or so. She's a veteran OBGYN missionary doctor, Dr. Monique Wubbenhorst. She is well known and beloved by the global Christian healthcare community and has shared her testimony and talked all about USAID programs and funding opportunities with large audiences at the Global Missions Health Conference in Louisville, Kentucky. Dr. Wubbenhorst is an MD grad of Brown University with an MPH from Harvard and was on the faculty at Duke University before taking the post of Senior Deputy Assistant Administrator at USAID in 2018. I want to invite you to listen in to part 2 of our program today. Well, in this unusual weekly program of CMDA, we're now going to present to you part 2 of this discussion about USAID and global health support relief. And, Dr. Barrows, last week I was just trying to think, who do we know that could give us some insight? And immediately, Dr. Monique Wubbenhorst's name came to mind. And why? Because she has shown up at the Louisville conference. She has shared among many of my friends. She's even been to the Mission Hospital where I practiced once upon a time back in the day. And I picked up the phone and called Dr. Wubbenhorst, and she was delighted to come join us today.
Well, I'm delighted that she's able to join. As we're going to learn, she's got a great history with USAID. She is a very bright individual, and I can say that because we had a really long conversation standing out in the cold in front of the Supreme Court prior to a recent hearing. So I'm very glad that she was able to make it with us today.
Well, I'm glad you had some stimulating conversation
Yes.
outside the Supreme Court. Well, Dr. Monique Wubbenhorst is a board-certified obstetrician gynecologist with more than 30 years' experience in patient care, teaching, research, health service delivery, and policy. And Monique, you told me last week that CMDA is to blame or to credit for having gotten you a job at USAID.
Oh, yes.
Tell us just a little bit
yes.
about that. How did you get a job with USAID?
Well, it was very interesting. I was asked to apply for a job in another agency. And when I went there, they said, oh, well, you spent a fair amount of time and done things internationally. Would you be interested in applying for a job at USAID? I didn't know very much about USAID at all. And so I went and applied. And at that time, I had just very little experience in dealing with sort of the government employment system. And CMDA's government liaison was extremely helpful in helping me to navigate all of those pieces in a way that I felt confident and not intimidated by all the hoops that you have to jump through. So that was really extremely helpful in terms of getting me the orientation that I needed to be able to put together the best possible package and to apply for the job.
So, Dr. Wubbenhorst, for 3 years, you were the Senior Deputy Assistant Administrator in the Bureau for Global Health. That's a really long title. So for 3+ years. So was it a politically related or personally related or some other reason for your change that you left the Bureau in 2021?
Oh, well, actually, so initially I was a senior advisor in the Bureau, but then was promoted to SDAA, Senior Deputy Assistant Administrator. And because political appointees serve at the pleasure of the president, I resigned my position the day of the inauguration. You actually have to, agree that that's what you're going to do prior to that time. Also, the Lord had already told me I wouldn't be serving in the new administration. So at that point, I considered myself to be kind of semi-retired. I was out of clinical practice at that exact juncture, and God had other ideas. So I took about 8 or 9 months off and then felt like the Lord was telling me go back into clinical practice. So I did. I went through all the steps to start up doing OBGYN again, full OBGYN. And then I also was asked to do a fellowship at the DeNicholas Center. I've been involved with the DeNicholas Center at Notre Dame for many years. And then somewhere in there, I started doing short-term mission trips to mission hospitals to give the long-term missionaries a break. These, as you all are, I don't even need to tell you this, people working day in, day out, and just separated from families, working under difficult conditions. And I felt, this is something that I can do to help them, to give them a break so that they can go on leave or go to a meeting or whatever. So I worked at Tenwick and at Elwha Mission Hospitals. And then most recently, I'm working with organizations in sub-Saharan Africa on very low-cost, sustainable healthcare.
Well, Monique, during your 3-year tenure at USAID, what were the funding priorities within your section of work there?
I had responsibility for the operations of the Bureau, the general operations of the Bureau, as well as oversight and development of awards, which was, research awards, grants, contracts, and cooperative agreements. And then interacted with Congress or implementing partners in the public under Dr. Alma Golden, who was my superior, who was the assistant administrator. So our portfolio included PEPFAR, a number of maternal child health projects, and our total budget, I think at that time, including PEPFAR, was about $9.6 billion. So one of our biggest and most complex challenges was COVID, because we were focusing very intensively on our priority areas, and then it was all COVID all the time. And it was very rewarding, but it was very challenging. My husband would say, I would get on the phone at 6 a.m. and finish at midnight because we were trying to work across all time zones and get ventilators. We were trying to help hospitals to come up with effective protocols for dealing with COVID, and that was shifting very quickly. So those were kind of the priorities that we had in malaria, TB, HIV, AIDS, of course, maternal child health, neglected tropical diseases, and so on.
So about a month ago, USAID closed down, and there's been a lot of conversation about this, and I've been hearing about it from global friends who've been doing HIV/AIDS. It's rare for any of our members to get an editorial published in the New York Times, but we've even recently had a couple of our members get a New York Times editorial published entitled, "As Fellow Pro-Lifers, We Are Begging Marco Rubio to Save Foreign Aid." So my question, Dr. Wubbenhorst, did this abrupt closure surprise you at all? And what are you hearing from former USAID colleagues? And you don't have to name them, keep their names confidential, but those who were working there when the changes happened, what's the scuttlebutt among USAID alumni like yourself?
Sure. So I think it was a bit of a surprise, but to be very frank, there have been problems at the agency for a long time, certainly even predating my time there. In fact, it wasn't until some of the reports came out that I think we really saw the sign of the depths of the really what I would say mismanagement and even I'll just go out and say it, corruption that was going on. I just want to be really clear that I am not here to defend or condemn the decision to shut down USAID, shut down in quotes, because it still exists as an organization. And despite what people say about people being fired, they're on administrative leave, which is different from being fired. And I'm certainly not here to litigate whether the president or anyone else, should have or not done that. But I do think there are things that we can learn from this situation and cautions for folks in the field based on what I'm hearing and what I've seen and in the past. One is that there's a sense in which, my colleagues who were there, not a sense, but it's very interesting. My colleagues who are still there, and some of them are Democrats, some of them are Republicans, don't feel that this is really a political decision. It's not. It's a decision to try to address some very deep and longstanding problems. And as I said, some are Democrats and some are Republicans for what it's worth. But they feel that this is hard, but it's justified. And it was a very interesting perspective to hear them saying. I thought that they would say, this is terrible. This is an outrage. Why are we doing this? But they felt that this is something that these problems have been going on for a long time. And it's impossible. They said this, and I think this is probably true. It's impossible to run an agency where, especially an agency that's as large and complex as USAID, where people are not just in disagreement about the goals of the organization, but refusing to accept instructions from leadership and actively working against those instructions. We understand as Christians, that our authority we need to have an appropriate relationship with authority. But even people who are not Christians, should have an obligation to listen to what their boss is telling them to do. So I think that there is a lot of uncertainty. There are a lot of questions about what is going to happen. And of course, nobody knows the answer to that. But overall, what I'm hearing is that people feel that this is something that the only way to deal with these problems was to do what is happening right now.
Well, I think I know you're aware, that we had a conversation earlier today with Echo VanderWal, the CEO of the Luke Commission Hospital in Eswatini, and we gave you the opportunity to listen to that conversation. So with that preface, I wanted to ask if you know the amount of USAID funding for healthcare work in a country like Eswatini and how it compares with USAID funding in other sub-Saharan African, Asian, or other low-income countries around the globe?
Sure. So I can't answer directly how much funding goes to Eswatini versus other countries because I don't have the budget in front of me. I do know that Eswatini is a priority country for PEPFAR, but remember there are different funding streams for countries. Some funding streams can be for malaria, some can be for HIV/AIDS, some can be for maternal and child health. And so different funding streams can kind of converge for a country. Eswatini has been a priority country, but the amount of funding varies widely from country to country. For example, if you look at overall USAID funding to Ukraine and Jordan, it's very high. And then as you sort of go down from there, the amount of funding going to different countries varies. And those decisions are made in sort of in the context of what are the current health challenges in a country. So I can't answer that exactly without having budget numbers in front of me.
Well, second part to that is outside of PEPFAR funding, which clearly covers ongoing operational costs of treating HIV/AIDS and preventing the spread of various diseases, what other kinds of operational funds, excluding capital projects, are given by USAID?
So there are several different ways in which funding goes to implementing partners who are usually either NGOs, or there can be G to G, government to government funding that goes on. Some funding is around supply chain. So, for example, if there are certain health commodities that countries are struggling to get, USAID had a very, very large supply chain project that would get these commodities into countries. USAID also worked with the Global Fund, which works on getting malaria and vaccines into countries as well. There are not that many capital funds except for a specific program on, targeting what's called the American Hospitals Abroad. But most of them focus on either hospital operations, training, health education, supply chain, commodities, along with the supply chain, and then direct patient care activities in the priority areas like maternal child health and HIV. So these are the kinds of funds that have been given in the past. And again, a big concern has been looking at where have funds gone. And I think that one of the issues that has come up is that it appears that funds that were earmarked for certain projects, sometimes those funds got to those projects and sometimes they didn't. And that's been a concern.
Before we continue with this week's episode, here's a special announcement for you. As a result of a partnership between CMDA and Alliance Defending Freedom, we are now offering free legal consultations for CMDA members who may be experiencing conscience freedom issues in the workplace. Exclusively available to CMDA members, this program is designed to serve members who feel they are being discriminated against in the workplace due to their firmly held moral and religious beliefs. If you feel your conscience freedoms are at risk, please visit cmda.org/legal to learn more about how we can help. Let's jump right back into this week's episode.
If you were back at USAID right now, and I know this is a little bit challenging because you've been away for 4 years and in an OBGYN practice there, but what would be your hoped for future and recommendations for bringing about restoration of critical funding needs and that short leash that Echo mentioned, that maybe just weeks of funding, even for the most critical HIV, tuberculosis meds, mother-to-child transmission of AIDS? What's best case scenario, and what are you hoping for to happen in the next 60 or 90 days?
Sure. So I do think that it's going to take longer than 60 to 90 days. And I'd like to use a horticultural analogy because I like to garden. So if I use a horticultural analogy, I would look at USAID as an unhealthy plant. It needed to be pulled up by the roots, and that's what's happening right now, and carefully examined. The bad parts need to be trimmed away, which will involve reforming the agency and probably some restructuring as well, and addressing those activities and grants and contracts and so on and so forth that are not aligned with U.S. policy. And then I think the agency needs to be directed to grow in a healthier direction with sunlight, with transparency. GAO, if you're interested online, GAO did an evaluation of USAID's Global Health Bureau in 2023. And it's actually a very instructive document because it shows that there are some fairly substantial problems in management and accountability even back then. And then there would have to be safeguards to prevent future problems. And those are legislative and agency policy prescriptions. I think that the solution to misuse is proper use. I think that it's possible to restructure and reorganize it so that the agency can be better than before. But I just have to be upfront and say that I'm not optimistic that funding is going to be restored in its current context. I think that it's going to take some time to disentangle all of the problems that are going on, and not just contracts, but way in which management is not aligned with administration policy. And I think there's going to be a lot of conversations about what is critical funding. What does critical funding look like? There's going to be probably, I would say, just sort of thinking about this, thinking ahead, there's going to be a focus on short-term funding leading to long-term sustainability, because in my opinion, the era of 5-10-year grants and contracts is over. I think there's going to be a much greater emphasis on data and monitoring and evaluation to demonstrate results. That was a problem when I was there. I think it continues to be a problem. As Milton Friedman said this really well, he said you can't judge how well a project or a plan or anything is doing based on the intent. You have to judge it on what the results are. And I think that we do have that. And then I also think that in line with the monitoring and evaluation piece, the question has to be asked. I think Echo talked about this. She did a really good job of talking about this. How do you facilitate not just healthcare, but development? In the absence of a development focus, healthcare problems are never going to be fully addressed. They're never going to be sustainable. The health system and the government are constantly going to be dependent on foreign assistance. And that can have some negative consequences. In some places, foreign assistance leads to governments saying, okay, we don't have to spend money on our population. We can take that money and spend it on, private planes and nice houses and cars. And I'm talking about things that I have actually seen, not things that people have told me. And finally, I think it's very important to recognize that the federal government does not fund these projects. The American taxpayer funds these projects. So the American taxpayer funds these projects. And right now, foreign assistance is really not a priority that most American taxpayers have. And it's not seen very favorably, especially in light of the emphasis on what was done wrong and not on what was done right. A case, I think, needs to be made to the American people as to why their tax dollars should go to foreign assistance, given that so many people are struggling to make ends meet. And I know that's not going to be a popular thing to say, but I know that talking to people, there's a lot of negativity around foreign assistance when they say we have so many problems here. And, there's always that tension. But I think that the case does need to be made because ultimately the government is not paying these bills. It's the taxpayer. So I don't know if that's helpful, but, that's one perspective.
Yeah, I think it's very helpful. So as you are likely aware, Monique, many of our members serve overseas in resource-poor settings like Echo, and they're likely dealing with a lack of funding from USAID and PEPFAR. So what advice would you give them during this waiting period?
Sure. And again, this is a tough situation. And again, like I said, every day I am hearing from partners and friends and colleagues around the world about this. I think that being very realistic, that the funds are going to be frozen for some time and may not be awarded at the previous levels. That's very hard to say. It's very hard to hear. But just as I was saying earlier, just disentangling the situation at USAID is going to be a lot of work. It may not be finished until right before the government fiscal year ends in either September or October. And that's difficult. That's going to be very, very difficult. But it's going to take time, and there has to be some agreement, I think, within the administration as to what constitutes critical life-saving care. And then there's a process that has to be gone through in order to get those funds put back into the grants and so on and so forth. So I'm not optimistic that that's going to happen in the next 60 to 90 days. I'm not saying it's impossible, but what I'm really encouraging people to do is to say that you need to be prepared for that. You need to be prepared for that, the fact that that may not happen. And what is going to be needed, in my opinion, is painful, but it's a combination of cutting services and getting funding from other sources to keep the doors open. There just isn't any evidence of things happening very quickly. And I understand that. If you understand how funding works and just the multiplicity of grants and contracts and cooperative agreements and awards that there are, it's just going to take time. And I think that part of that one of the reasons I have to caveat that is that there's clear evidence that instead of sending grants where they're supposed to in a timely way, people were diverting grants to specific causes or partners that they should not have been doing. And so disentangling that, as I said, is going to take some time. So I think it's a situation where we're praying hard for our partners, but my opinion is that it's better to be prepared and to go and seek those alternative funding sources and see what needs to be done in terms of restricting or reducing services and not just to keep things going.
Monique, that's really helpful for our listeners and for Jeff and I to hear. Guessing that with the cycles that go through our federal government, I was just telling Jeff earlier today that I saw some numbers online that USAID has gone from 10,000 staff down to around 250 staff in a very short period of time. And I've got to believe that 250 number is going to climb back up. And so as people are listening in, and with your experience at USAID, who should pay attention and maybe think about service just like you did at USAID in the future as that 250 number, I've got to believe it's going to climb again?
Yeah, I think you've got your finger on very important issues. Let me just take a step back from that. So one of the issues is that political appointees, when I was there were only 180 political appointees for a total staff of 10,000. And so you can see that you could have a presumption of good faith on the part of the people that you're managing, but it was impossible to oversee everything. I think the reason that things have shrunk down so far is the recognition of that asymmetry, that you've got to have career people. And I met wonderful career people, absolutely amazing career people, but you need career people who understand the ins and outs and the logistics of running USAID. It's complicated. It's not overly complicated, but it just takes some time to learn. I think that there's a need for people, and this is certainly not a plug for me to work there, but there is a need for people who were in the previous administration to be able to come back. And then I think there's a huge need. One of the problems that we identified that speaks directly to your question is a real lack of global health expertise and health expertise in the agency. There are reasons for that. Part of it is the fact that, you had previous emphasis on vertical programs, and now our programs are more horizontal. And you could say, the vertical program is the circle and the square of the horizontal integrated program. But there's a tremendous need for people with clinical experience who've been on the ground, who have done this type of work, to be in positions where they have operational responsibility. I can't emphasize enough how that is a need that I think members could actively participate in and help with, because that was something that was a real struggle, especially with COVID.
Well, I want to thank you for taking time out of your afternoon today, Dr. Wubbenhorst, and answering our questions and being a part two. I trust that our listeners will have learned a great deal. There's been a great deal of mystery and controversy out there as our members, Christians, non-Christians, have talked about this. And, there's the old famous quote, America's great because America's good. And if America ceases to be good, it will cease to be great. And we've been hearing a lot about a great America. So it's this former missionary's heart that we will be able to convince the grassroots taxpayers of the United States that it's good for us. I can't tell you how many thousands of thank yous I got from people on the ground when those big USAID signs went up for a new eye and dental hospital, as well as our PEPFAR clinic. I mean, it was such a good bridge, and it just opened doors for us as Americans serving in East Africa. So I'm praying that there'll be a lot more Monique Wubbenhorst out there willing to engage and invest in putting our tax dollars to good use in the future.
I appreciate that, and I do think there's also a role for our churches to step up. We are we're a wealthy country, and I think that there's a way in which our churches can step up and help make the case to the people. Tell the stories. People don't know the stories of what we do. Mm-hmm. Either at USAID or your years at Tenwick and years in the field. People need to see those stories. They need to see videos of those stories. They need to listen to the people who have been helped, and that's not out there right now. And so I think there's this distrust and suspicion and dislike right now, and that could be addressed. So I don't want to go on too long, but I did want to say that. I think that you're onto something very important there.
Well, it's clear with all that you've shared with us, Monique, that we need to make this a matter of prayer for all of those hospitals and clinics around sub-Saharan Africa and Asia over the next several weeks and months. But in the meantime, I'm very thankful for your perspective as someone who has spent 3 years at USAID. It's been very helpful, opened my eyes, and I'm sure also will do the same for our listeners.
Yeah. God bless you, Monique.
Thank you. It's been an honor to be here. God bless you, gentlemen, and thank you so much for having me.
Missional living in healthcare has always seemed a little bit like swimming upstream. Sometimes because of challenging circumstances or family situations. Sometimes it's because of antagonism or a lack of funding or support. Our culture and workplaces and institutions today are not as friendly to faith as they once were. Living in obedience and on mission for Jesus Christ and setting biblical truth as our true north, it can be hard today, friends. If you'd like some genuine and timely encouragement about serving those in need in the U.S. or on foreign soil, the Remedy East Conference will challenge you to grow in your understanding of what missional living actually looks like. Would you join us at Liberty University in Lynchburg, Virginia this coming April 11th and 12th? And there you'll be able to explore mission opportunities and to serve and expand your skills and your knowledge. We'll gather for worship together, learn what missional living looks like in our own lives, and invite our Lord to shape our hearts and guide our steps. I'll actually be sharing in the final plenary session on the sacred, oft surprising, and sometimes scary call of God. If you'd like to learn more and to register, just go to remedy.cmda.org. Next week on the podcast, you're going to hear the incredible story of a man who truly epitomizes a life redeemed, and not just spiritually redeemed, but remarkably redeemed from his mother's womb. Join me as I talk with Emmy award-winning artist, author, and upcoming 2025 CMDA National Convention speaker, Mr. Ryan Bomberger, as he describes his journey from becoming an abortion statistic to the voice of opposition against a victimhood mentality in our culture today, as well as gender and race politics and more. It's an amazing and transformative story that you don't want to miss. And don't forget, you can catch up on all the episodes of CMDA Matters. You can find those on our website at cmda.org/CMDA Matters. You can also find us on the CMDA Go app, which you can download by going to cmda.org/app. You'll also find us on Apple Podcasts, Spotify, or wherever you listen to podcasts regularly. Until next time, as Christ told us in Matthew 6:33, keep on seeking first God's kingdom and his righteousness, and these things, the kind of things that the Lord knows that we need for life and health and well-being for ourselves and those that we serve, friends, will be added to you as well. Those are the priorities that matter to CMDA, and CMDA matters. We'll see you next week with Mr. Ryan Bomberger, God willing.
Thanks for listening to CMDA Matters. If you would like to suggest a future guest or share a comment with us, please email cmdamatters@cmda.org. And if you like the podcast, be sure to give us a 5-star rating and share it on your favorite social media platform. This podcast has been a production of Christian Medical and Dental Associations. The opinions expressed by guests on this podcast are not necessarily endorsed by Christian Medical and Dental Associations. CMDA is a nonpartisan organization that does not endorse political parties or candidates for public office. The views expressed on this podcast reflect judgments regarding principles and values held by CMDA and its members, and are not intended to imply endorsement of any political party or candidate.